What you have is something invaluable even for scientists abroad, right?
Yes, they are collaborating with us for that they want the data first. So we have a lot of
data is the new god.
data is the new oil.
How artificial intelligence can be used to detect lung cancer.
Lung cancers can be small and they are not detectable by X-ray. So this is where AI can come in. These often detect lung cancers very early, even before they are visible to the human eye.
The AI information says that this person is going to react badly to the drug. But clinically, as a doctor, you would have thought that I have used it on 15 other patients showing similar things.
Oncology has progressed because of clinical trials. Clinical trials is the epitome of the advancement of medical research. It has been shown in literature that patients who participate in clinical trials have much better outcome. So even if a new drug comes in, there are 10 years of testing happening on it, on animals, on laboratory models, on retrospective analysis or toxicity profiles, effectiveness profiles, before it reaches the patient.
What are the challenges currently that you're facing which difficult to overcome?
AI models are essentially working on digital data. They don't work on analog images or analog data or paper records. Not more than 10% of our hospitals in the country use electronic medical records.
It's just prescription ऐसे लिख के
पेपर पे लिख के दे देते हैं.
Namaste, Jai Hind. You're watching or listening to another edition of the ENA podcast with Smita Prakash. This episode is being filmed in Mumbai, and my guest today is Dr. Swapnil Rane. Cancer is a critical public health challenge in India, with cases projected to rise significantly in the coming years. According to the Indian Council of Medical Research (ICMR), the estimated number of incidences of cancer cases was more than 14 lakhs in 2023. In India, 1 in 9 people are likely to develop cancer in his or her lifetime. Lung cancer in men and breast cancer in women were the leading sites of cancer. There's a lot of chatter these days on the use of artificial intelligence to detect cancer. To discuss this, I have with me Dr. Swapnil Rane, Professor of Pathology, Tata Memorial Centre, AI Research Lead. Dr. Rane, thank you so much for coming for the podcast. There's a lot of research one is reading, and almost every day there's an article in the newspaper. The latest I read was that 60,000 people die in India every year due to lung cancer and 1.8 million worldwide. Can you explain how artificial intelligence can be used to detect lung cancer in particular? Because that seems to be a case that we're reading. And since I've come from Delhi, that's a major issue because of pollution, air pollution, and things like that. And the data also shows that the number of people suffering from lung cancer in North India as a result of pollution is increasing literally by the months.
Right. So thank you first for inviting me here. It's my pleasure to be here. Let's talk of lung cancer. So if you look at data from India and compare it to data from West, you see that 95% of our lung cancer patients are already stage 4 by the time they are diagnosed. On the other hand, it's reverse in the Western population. Not more than 20% of their patients are stage 4. What it really means is that we are not detecting patients early. All patients are not approaching doctors early. And that is one of the biggest factors that is responsible for the mortality. So if it is an early stage, you can actually excise the tumor and the cure rate increases dramatically.
Okay.
But once it is stage 4 or what we call metastatic disease, we are not looking for cure. We are looking for managing the tumor. Of course, around 10 years back, the mortality rate of a patient diagnosed with lung cancer, it would be around 12 months. That would be the life. That you would expect 80% of people with lung cancer diagnosed to be dead by 12 months. That has now changed, and that is largely because you now have genomic methods to detect targeted mutations, and you have therapy against those. So now you have people surviving for 5 years, some even up to 10 years.
After stage 4?
After stage 4.
Okay.
But eventually they succumb to it.
Yeah.
But now you have something that prolongs the life in a very good way, because these are targeted therapies which target a specific mutation in that cancer. But eventually some other mutation comes up and there is resistance coming up, evolution of cancer happens and the patients succumb to it.
So, Doctor, when the breast cancer cases were becoming very common and prevalent, there was this whole campaign on how to detect it, which you can detect at home. You touch and feel, and then when you feel a lump, then you go to the doctor, get a mammogram. There was an entire protocol. For lung cancer, is there a protocol that you can check at home, detect the signs at home, and you know that there's something wrong, and then go to the doctor?
Unfortunately, by the time you detect it becomes detectable by the patient, it is very late. Because the lung is seated deep inside your body, and the lung has a lot of extra capacity. So we don't really use the entire lung capacity. So we don't come to know until the lung capacity drops dramatically that there's something wrong with it. And so that is one of the problems. So unlike breast, there is no. If the patient feels a lump in his neck, it is too late. If he is feeling breathless already, it is too late, because most of the time these are stage 4 disease. So
Breathless as in when you climb stairs or just generally?
Regular activity. So even climbing one or two stairs, one or two flight of stairs, if you're feeling breathless and you are otherwise a smoker or things like that, then it is too late. It's already probably spread.
So it's not necessary for the sputum to be black in color or having blood or anything,
No,
because
so
those were the earlier signs.
Those are the signs. Those signs are there. So if you get those signs, yes, you should get it evaluated. That is definitely there. But many of times these are quite late.
But why aren't these scans part of your daily, not daily, but I would say your yearly tests that you do? For example, if you're testing for blood pressure, blood sugar, when you're doing all this, why are cancer tests not part of that?
So X-ray chest is often done when people who get themselves screened annually often do get an X-ray chest as a regular screening. But lung cancers can be small and they are not detectable by X-ray. We obviously don't do a CT scan of the lung as a routine procedure, as a screening procedure. That would detect it earlier. That is one thing. So this is all where AI can come in.
Right. So you're working on that.
So,
let's get to that.
So one of the easiest ways that the X-rays can be screened by AI models, and these often detect lung cancers very early, even before they are visible to the human eye. Okay. So and they can even, there are some companies as well. There's a lot of research happening to differentiate between cancer and other pathologies in the lung. So in India, obviously TB is such a big thing. TB is much more rampant. So if you have something on the lung, there's a very high chance it is TB more than lung cancer. But visually, it will be very difficult for a radiologist to comment on that.
They'll just see a patch.
They'll see a patch, and then you investigate further, and then you dissect it out further. But AI models can actually be trained. This is a X-ray from a proven lung cancer patient early on, and this is a X-ray from a proven TB patient early on.
So it's the same test, but the
interpretation is by somebody, by an AI model, assisted by an AI model.
Okay.
Now, it is not a magic bullet. It all depends on how the model has been trained.
Okay.
And a lot of testing has to be done. And the AI model that is trained in India may not, let's say in the rural parts, may not work the same way as if it go to some other location. So let's say that because the prevalence of other diseases keep changing. So you don't have TB equally in every population, right? You have different population. Different people, there in different populations have varying levels of smoking. They have different types of smoking. There's BD smoking, there is regular cigarette smoking, and chewing tobacco and things like that. All of these are affecting how the AI model sees the image.
So the LLMs are different in all this. Yeah.
So one of the things, I'm a pathologist by core training, so I look a lot at tissues on the glass slide. Now, when we were training models on the pathology images, what we realized that because Western data is publicly available, we first trained some models on those. And then we tried to simply apply those on our Indian patient as a testing procedure. What we realized, the performance dropped dramatically. So on the Western, the model that was trained on Western patients would perform around 86 to 90% accuracy on their data sets, but on our data set it dropped to 50%. 50% means toss of a coin. It doesn't really mean anything. It has no value.
Okay.
The reverse also held true. that we trained it on our patients and it performed very well on our patients, 80%. But the moment we tested it on the Western data sets, the accuracy dropped dramatically. So what really that told us, what are the possible, why should it happen? It is same lung cancer on both the slides, etc. Then we kind of tried to look at both the images and saw that there was some background things were different. So we had a lot of carbon pigment soot material from the pollution, from the smoking, etc. in our tissues, while the Western tumors were free of those carbon pigment. And the model was getting confused by these factors. So the model, what the problem with AI models is that
we need an indigenous one.
We don't know what they are focusing on. The trick is to make them focus on the pathology that we want them to focus on. If you simply give them images, it might just look at the backgrounds. For some reason, the background might be slightly different between the two data sets, and then it will pick up that as the factor.
Okay.
So that is where the problem lies.
Okay.
Another example where AI models in lung cancer can really make a difference is today, as I said, we have those genetic tests and patients are getting treated with targeted therapies. But to reach that decision, it takes around 6 to 8 weeks. So from
that's
the
critical
diagnosis
time.
To the actual genetic test results coming up so that we can start the treatment, it takes 6 to 8 weeks minimum. And of course, there's a price factor along with it. Now, what can now happen is that AI models, because what happens is when we do the biopsy, we first do a routine pathology and then the genetic testing starts. Now, the AI models, we have been training on the routine pathology to detect the mutation directly on the image.
Okay.
So, at least in a proportion of cases, we should be able to identify the mutation with very high accuracy very early on.
And is this true of all kinds of cancer? Is this detection by AI that you're using, the tissue in, say, cancer of the blood, cancer if you have of any other organ or
potentially yes, but it always needs to be tested out in a very rigorous manner because as a general rule, the how the cancer looks will be affected by the genetic mutation. Okay, in most of the situation, it happens that if there's a EGFR mutation, it looks like a certain type. If the EGFR mutation is absent, the tumor looks slightly different. But these differences are not visible to the human eye. So this is where the AI model comes in and it picks those differences.
So are doctors adapting to it because it is still at the early nascent stage in India? I'm sure it must be used more in the US. Are doctors adapting to it or are they still wary of AI models like this?
They are a lot wary of it. And to be frank, many of these, there are very few AI model tests of this kind in routine practice. Even in the US, the adoption is slow. And it is fairly so because you need a lot of testing, not just testing of the models in different scenarios and situations. Regulatory agencies classify AI models as a medical device. So it has to undergo all the testing and rigorous as a medical device would have to go. So, or a new drug would have to go. So it takes around 10 years time for any model to go through the entire process to reach a marketable stage. The other thing is that because the medical doctors in general, it's how we train our doctors. We give them the option at a very early age. You take either maths, physics, chemistry, or you take biology and then do medical science. So that division that has happened very early on, and most of the people who take up medical field are people who don't like computing science or mathematical science. So there is a divide very early on. Most of medical people don't understand statistics very well. So all of these factors make a difference. And
I guess it takes a little time to adapt. For example, robotic surgery is not something that was initially when it came, everybody was suspicious of it. That how can you get a robot to do it? A surgeon का जो हुनर है, वो एक machine कहाँ कर पाएगा? So that was the thing. But now robotics is something which is integrated so much into the medical profession.
Exactly. That is how it goes. It obviously also makes a difference if the price point is lower. So initially the Western medical robotics were not very easily accessible, but now you have Indian companies manufacturing robotic systems, so their price points are much lower and therefore they are much easily adapted.
So, on the one hand, we're talking about the skepticism of doctors to adapting to AI, which I can quite understand because there's so much of negative information also on AI which comes in. But even patients and then insurance agencies, because now increasingly in India it's becoming like it used to be in America, where any kind of curative process that you need to do, any kind of surgery that you need to go, you need an okay from the insurance companies. Now, if the detection has been done by AI, are insurance companies also on board that, okay, we have to go in for, mastectomy or whatever you want to do because AI has detected it? Will insurance companies go with that?
So if it goes into the regulations, yes, I think they will adapt to it, but not as of today. Because it is not a standard practice. Insurance is all about trying to get for the extreme situations. You have a lot of they always have clauses which are not covered. And currently this thing is not in the clauses which is covered. It is not even mentioned in the clauses which is not covered.
Oh, really?
Right.
So it's still
AI
experimental?
models, all of this is still in the research phase because it takes a lot of time to do all the testing, and somebody has to take the lead to do all those testing. So that is why startups and companies come up, because you need dedicated and focused people working on one or two technologies and take them through the different testing phases and the different clinical trials.
Yours is not a startup though, right?
So we are not a startup. We are, yes. So most of the time what happens is academic institutes and hospital setups like us, if we do come up with some model, etc., we will file a patent for it and then we will license it out to any company. If there is somebody amongst us who is entrepreneurial, then he will start a startup, try and go through that entire process. But things are changing. So now many just like IITs allow their faculties to have startup companies, okay, there is a call that even medical professionals and medical organizations should allow, medical professionals should be allowed to do this kind of work. Currently there is no such background in India at least. So for example, in TMC, there is a process ongoing to set up a Section 8 company within Tata Memorial Centre, so that we can now have smaller startup companies within TMC, which we can focus on the marketing and the development of the idea into a commercially viable product.
So currently at this stage, we are still, or India is still at the stage of using AI only for diagnostic work, right? Nothing more than that. Even that you're saying is just in the nascent stage.
So, for example, there are companies which are marketing AI algorithms on the radiology side. Some of them have received FDA approval and their regulatory approval. They are there in the market. People have to adopt them. And when you adopt, then you still have to test them out on your patients, because as I said, a model which is trained on A type of radiology machines may not work on the B type of radiology machines. Hopefully the companies take that effort to make models generalizable, that they will work in multiple setups.
Even with medicines, like for example, what I've heard is that, say, like a medicine which is, say, of oncology, when used on patients in America, there's a lot of side effects that came in. But the same medicine, when it was used on Indian patients, that kind of side effects were not seen. So how does that work with AI models then? Like, you'll have a data set which has to be very specific to Indian gene, and Indian gene also is like varied, right? There's nothing called an Indian genetic makeup.
India is Europe. You have so many subpopulations and so many cohorts within the Indian setup. So yes, that is true. So if I make now we have 10 centers across different parts of the country. What we are doing is, whenever we initially build the model in Mumbai on a certain set of population, we are pushing it out to our different centers to test on those populations. Because even if they are TMC, they are physically located at slightly different parts of the country.
And
so
you saw a difference?
There is a difference.
Okay.
So what we then do is, okay, let's try and teach the model it essentially what it means is that the model is not 100% focusing on the tumor biology. It is focusing on other things, okay, which are slightly different from population to population. So we try to make the model, as I said, it try to make the model robust to such variations so that it can focus. It is not an easy job. It is not, often we fail at it. That with current technologies, we then try and get in the engineering teams to build their more novel methods so that they can, the model becomes more robust to this. So all of this is working. So,
and especially for early detection, and if there could be kits, and I don't see why it can't be done. COVID was something which happened, which was new, right? But somehow the medical community came up with those COVID kits which we could detect at home. So if that can happen, and when you know that cancer is so prevalent in India, why can't we have that?
So COVID was an exception in a lot of ways, even for the regulatory agencies. So most of the kits and most of the methods got rapid clearance without going through the entire process of, giving the urgency of the situation. It was done. But whether they will be willing to do it for something that is a long-term problem and not a sudden acute problem, that is.
But because of the enormity of the crisis that we have at hand, I mean, if we can have diabetes kits where we can, poke ourselves at home and check whether our sugar levels are increasing, and we modify our diets, we modify our lifestyles because we know we're pre-diabetic or we are heading towards pre-diabetes or we're heading towards obesity. You get those checks done. You can do those checks at home. When we realize that we are getting into, the numbers are frightening of the cancer prevalence. It used to be like, till about 10 years ago, you knew of one person in your friend setup who got cancer in his 60s or in her 60s. Now you're talking about everybody around you has some form of cancer or the other, which is quite frightening. So why is the country not hastening research, one, two, funding for the research, and three, these regulatory mechanisms?
So it is not totally fair to compare cancer with diabetes, but because the spectrum of cancer is too wide. You have cancers occurring in younger populations which are very different. Cancers occurring in elder people with different. There are occupational hazards. There are other conditions, other predisposing conditions. People are exposed to a lot of pollution and things like that. There are some tests available in the market which kind of screen for all cancers possible. There are some standard tests which can be done on blood tests. They are essentially screening tests. Mean they are not diagnostically accurate, but they at least tell you, okay, that you have something. You can now go and do further testing. So there are some tests like that, and they are part of many of the annual testing that happens. People subject them to. So those common cancers, for example, breast cancer, we have the mammography and the physical examination. For prostate cancer in males, we have the serum PSA, which is a standard blood test that is done. You have other CA and some other blood tests that are available for other internal organs. So even for lung, we can do these. So the CA and things like that, they are not specific to lung, or they can come from many cancers.
Okay.
So some of these tests don't tell you exactly where the cancer is, but there's
some marker which tells you that
there is something wrong, and the cancer is one of the possibilities, and you should probably get this evaluated further. So there are tests like that, and they are routinely done in laboratories. As far as funding is concerned, there is enough funding in the ecosystem, but just that the researchers have to take an effort to really write coherent and very well thought of proposals and get those fundings. There is a lot of funding, and the funding has now increased significantly. So even after the focus on AI and etc., a lot of funding is coming in, but one has to. It is always we always have more demand than supply.
Okay. And the technology is available, or do you have to import the technology?
No. Technologies are most of it is homegrown. In fact, most of the models that are built by even Western companies are written by some Indian guy sitting there.
Okay.
So IITs and ISCs, and they have very able people. We in fact also at TMC we are recruiting a lot of them to work with us to build the models in house and work on all of these things. So we have a small team and we are now expanding it. So just tomorrow we have a high performance computing center at TMC which is being inaugurated tomorrow, and we are actually setting up an entire department of computational oncology to focus on.
What about using AI for precision medicine? Like we've talked about diagnostics. What about for medicines, for curative purposes then?
So today what happens is you have these treatment pipelines and guidelines. Okay, that you have, let's say a patient coming with breast cancer. She undergoes some staging procedure to evaluate how much is the tumor spread. She undergoes a biopsy to identify what is the biology of the tumor. You do some tests and based on that you devise a plan. Okay, should we do upfront surgery or should we give some chemotherapy first followed by surgery, or is the patient non-operable and should undergo some chemotherapy, radiation or some targeted treatment and things like that. The problem with this is in each of these groups, some patients benefit from it, some patients don't benefit in the sense that they recur very fast. Okay, so for example, you have HER2 positive breast cancer is one of the types of breast cancer. It's detected on pathology and genomic testing and on immunohistochemistry. If you have HER2 positive breast cancer, you get a certain type of drug called Herceptin, and now there are many Indian analogs of it. But we know that 30% of the patients who receive that drug will benefit very well and they will have long-term survival. 30% of them will not respond to it and immediately relapse within a span of a year. And the remaining 30% would have some kind of a mediocre response. Currently, we don't know which of these has benefited the most.
We don't know.
As in, we can't identify them upfront.
Okay.
We have to wait for the event to happen. Okay. So there are many studies. People have tried a lot of genomic studies. In fact, one of our studies are recently published on these areas. But AI is also useful in this scenario.
So like you can use AI to say, so this patient, suppose she comes from Nagaland and this patient has come in from Gujarat. They both are showing similar stages of breast cancer. You can use AI to detect that, okay, this medication with chemotherapy will benefit this patient from Nagaland better than this patient. Is that what?
Yes, that is what we are heading. That is what we are heading towards.
Okay.
We have now past data, right? All these patients received this particular drug, and we know that what happened to those patients.
Okay.
We feed this information to the model that otherwise these patients are very similar.
That she came in with that 30%, which showed that not very good response. So it is better to give her the other drug. Which will have.
So now the model will find the differences for you.
Okay. But you need to have enough data sets.
For it. So without data, AI models do not work. You need a lot of data.
So for you to get that data, patients are allowing you to give their information. Do you need to get their approvals before putting it?
Yes. So as a standard practice, consent is mandatory.
Okay.
It is mandated by the ethics committees to have the patient consents. Now there are some situations where the ethics committees allow a waiver of consent. These are very specific situations.
Ethics committee of the hospitals government.
So government agencies have mandated that every organization, medical organization or research organization will have an ethics committee. If they don't have an ethics committee, they will submit their proposals to an external ethics committee to get it approved before conducting any research. Okay. So the ethics committee approves whether a research can be done or not done. Ethics committee is a mixture not just of medical people, it has general population also, experts from other domains, from the social sciences, from other areas, as well as from the biomedical sciences. Legal lawyers also are on board, economists are on board. So it's a multidisciplinary committee which assesses what is the impact and is the study defined well enough that it will answer the question that is supposed to answer, and are any of the rights of the patient being affected by it.
Okay.
So in some situations, it allows that you may not take a waiver, may not take a consent, provided it is we are not affecting the patient management as such. So most of the time, these happen. This kind of waiver of consent are given to retrospective studies. So where the patients have completed their entire treatment protocols and things like that, and we are only observing and analyzing the data. We are not doing anything to the material or to the patient. We will not contact the patient at any point of time.
Okay.
But if you ask me as a general rule is that you have to take a consent, especially for anything that will affect the patient in any way, whether it is economically, mentally, physically, or in the treatment and the outcomes of the patient.
So here I would wonder, suppose like if the AI information says that this person is going to react badly to the drug or is not going to show much improvement with that drug, but clinically as a doctor you would have thought that I have used it on 15 other patients showing similar things. Now if that conflict comes, then which one wins better, the machine or you?
So no, it's a process. It is a step-by-step long process. So let's say that I want to work in that area, that I want to identify these patients who responded and didn't respond to a particular drug. I gather the data, I take ethics approval and do everything, and then I train a model on, let's say, 1,000 patient information on retrospective data. Once I see that, okay, on this data it works, I will do an internal validation by taking another 1,000 patients, different patients, and do that same analysis and see if that same model works equally well. Once I see that, okay, it works well, then I send it out for multi-institutional validation. Okay, now I do the same study in 10 or 5 different organizations and I get a result. Now I have tested it on retrospective data on multiple organizations. Now I put it into prospective testing. In this case, I will now start taking consent from the patient that we are going to do this test. At this point, we will not change our treatment, but we are potentially in the future we may change the treatment. Today we will not change. In the prospective cohort over a 1 year, 2 year period, now if we get similar results or same results, then we will now write a clinical trial where we will modify the patient's management. That when the patient comes, we do this test. Depend if the model says that this patient will respond, this patient will not respond. We do put in randomly 50% of each of these categories into the treatment arm and some other treatment.
But who wants to do that? Be part of clinical trial?
But that is how that is how oncology has progressed. Oncology has progressed because of clinical trials. Clinical trials is the epitome of the advancement of medical research.
Because I think you're at literally God's door. So you will agree to clinical trials?
No, it's not that. It has been shown in literature that patients who participate in clinical trials have much better outcome.
Okay.
Because it's not that these studies are random. They go through a lot of testing before it is even reaching there.
Okay.
So even if a new drug comes in, there are 10 years of testing happening on it, on animals, on laboratory models, on retrospective analysis or toxicity profiles, effectiveness profiles, before it reaches the patient.
Okay. So what are the challenges currently that you're facing which difficult to overcome, and what would you need in India? You in the sense of doctors.
As a general thing. One is the biggest thing that is required is access to data, the availability of data. Now, as you realize that AI models are essentially working on digital data. They don't work on analog images or analog data or paper records. Even if we have paper, we'll have to convert it to some form of a digital record before we can go there. Not more than 10% of our hospitals in the country use electronic medical records.
It's just prescription ऐसे लिख के
पेपर पे लिख के दे देते हैं. So फिर how, even if you are not a research organization, if you want to implement any of these AI models, only implement and only do your testing on your patient for your use case, you will need electronic medical records. How will the model work on them?
Yeah.
Similarly, pathology images, radiology images, or any other images, you need an entire system to manage those images in a very well organized manner. This is not there in most of the hospitals in our country. So this is a problem.
But I think the bigger hospitals now, it's mandatory for the doctors to feed in this information.
So in almost all private setups, this is mandatory.
Yeah.
In government setups, it is not. So, but essentially, it is not because of lack of mandate from the government side. It is because of the resistance
But
from
also
the medical
volume
domain.
of patients that the doctors see to feed in used to be a cumbersome process. You needed another human being in the room who will type in, what are the symptoms and what is the prescription, what has happened, what is the process. And after the patient is discharged, on the day of discharge, all that work. But now I'm hearing that AI is being used even for that.
Yes.
So could you tell me how that is happening?
So a lot of things are happening on voice recognition as well as there are now some systems in testing where you don't actually dictate to the model. The system is observing everything and making the entire record. So it is observing the interaction between, let's say, you and me, and I'm not specifically telling the system what to write or what to. It's interacting and transcribing on its own. Pretty much how the Zoom meetings are transcribed automatically. So a lot of these things are there, but it is difficult at times because, especially it's in a government. If it is okay when you are doing one-to-one kind of correspondence, but in a government setup, etc., you have 10 people sitting simultaneously in the same room. You have multiple patients.
But you need a human intervention at the end of it. But at least the first data has already gone in.
Correct.
So you don't need a note taker who will do that.
A lot of this is now sorted. So data entry is not a big problem.
Yeah.
The problem is in adoption of it.
There's still resistance you feel from the old guard or even the new guard doctors?
No, new guard is, I see many as I said, in the private setup, I have seen this happening very fast. Even people who are working on their own as a single setup or a clinic also, they have started taking a lot of these digital technologies up front very well.
So I'll tell you from a patient perspective, in the sense that most people that you talk to, I mean, I'm sure this will sound very layman, but I just want to tell you that the lots of people that I've spoken to, they said, doctors आजकल हाथ भी नहीं लगाते हैं. That everything is so dependent on test. हम लोग बात करने से पहले वो लोग 10 टेस्ट लिख देते कि ये टेस्ट. सो एवरीथिंग इज क्लिनिकली एग्जामिन ही नहीं करते हैं. सब कुछ इज बेस्ड ऑन द टेस्टिंग प्रोसेस. सो देर इज स्टिल दिस सस्पिशन अमंग मैनी पीपल दैट ये आधा टेस्ट तो चाहिए, देखो नॉर्मल आ गया. फिर भी डॉक्टर डिडंट इवन वो टॉर्च लगा के देखा नहीं, स्टेथोस्कोप लगा के देखा नहीं, टच नहीं किया.
Yeah, so we often want the human touch and the human element in it. Yes, we agree to that. There are some interesting studies actually there that where they compare the empathy of a doctor interacting with the patient and the AI model interacting with the patient. And they found the AI model, the patient didn't know who they were interacting with because it was happening on either some machine or whatever. And the patient in most scenarios classified the AI model to be more empathetic than the medical doctor. Now that is a lesson.
Again, it depends on the data that you're putting in there and the behavior that you're putting into the...
Correct. So it all depends. So yes, it is happening in a lot in that direction that that we are focusing more on the technology. But people who have spent a lot of time in it still vouch for the touch of the human element as in the interpretation of it. The normal results are equally important than the positive results.
Okay, so what I want to ask is another thing is like when you go to airports in America and all, you have those big machines, right? You stand like that and the machine goes like that and it sees whether there's anything. Will we come to that stage with AI that I enter a hospital, I stand like that, and it's given me the entire thing. It's given me my blood group, it's scanned me, it's done. I don't need X-ray for each and every part of my body. It's done this random thing, and if there's cancer, I get to know.
Potentially, yes.
I would want that. Very Star Wars, but I just want to know.
Yeah, exactly. It is Star Wars at this point. It is still a fiction at this point. But a lot of small things are happening. The big part would be to putting all of this together into a single machine.
Yeah.
Okay, so you have not just the X-rays or mammography, but you have infrared imaging. There is a company called Miramai Technologies, which is focusing on infrared imaging interpreted by an AI model to identify breast cancer early.
Yeah.
So the thing like that is happening.
Because like for a common person, it is such a tedious exercise to go from room to room to room every year, once a year. पहले इस वाले रूम में जाओ, फिर इस वाले रूम में जाओ, फिर यहाँ पे ब्लड टेस्ट, फिर उधर होगा, फिर यहाँ पे एक्सरे, फिर EEG, फिर ECG, फिर and after you're in your 50s, you have to get all this done anyway. Otherwise your insurance is not going to clear you for anything.
Yes. But AI models is going to change that, because what is going to happen is the same method which was not used for a particular cancer type might now be using for that. So for example, I said in X-ray, you can't really see the lung cancer very easily. But with AI model coming in, you can actually see it much better. You can, we need not really do a CT scan at some point of time, not today, but at some point of time.
Okay. Finally, I would like to ask on this, is India lagging behind, leading, keeping pace with the rest of the world in using AI for diagnostics and for pathology, for the various aspects of it? Where are we in the world?
In terms of using what is available, we are pretty much there. But the most of the newer technologies actually come in the West first and then get transferred here. Many of these technologies are actually manufactured in India and sold in US. So I know of at least 3 or 4 companies who have the manufacturing base in India. But because it is not easy to sell in India, they have their entire operations in US.
Okay.
Okay, so pathology scanners, as a specific example. There are 3 companies, some of them based in Bangalore, some in Pune. They have one leg in India, one leg in US. They manufacture it here, and they have the research center here, they have manufacturing here, but they sell more in the US than in India. One is the cost factor of it. And the other is, as I said, the resistance from the medical community to go very quickly. So see, it takes a lot of other skills than medical skills to really adopt these technologies. So as a medical doctor, if I want a particular technology, I have to master not just medical information, but grant writing skills, the people skills in convincing my superiors and my administration that yes, this is required.
Okay.
Budgeting it out, finding the money, getting it through the entire purchase procedure and things like that. So it takes a lot of other skills which are not taught as a part of your medical process.
So how long has Tata Memorial been doing this?
So we have electronic medical records since early 2000s.
Okay.
Radiology is digitized since that time, the early 2000s. Pathology is being digitized since last around 5 to 7 years. It is not completely digitized yet because we have very high volume. We generate around 8 to 10 lakh slides a year. And every slide we scan, it generates 2 GB of data. So if I have to scan everything in Mumbai, then we need about 1.5 to 2 petabyte of data storage on the first year.
And if it's around the country, then?
So that's a lot of things. So technologically, a lot of things are there.
But your data or what you have is something invaluable even for scientists abroad, right?
Yes, they are collaborating with us for that.
Yeah.
That they want the data first. So we have a lot of...
data is the new god.
Data is the new oil. They want the data very
And they would want to know how, the way their medicines or your medicines and how everybody is reacting in India, right?
So, and it is important to do this on multiple populations. As I said, AI models work differently in different populations. So it is important that the same model is tested on multiple populations.
Okay.
So towards that, what we have done is we have something called the Cancer Imaging Biobank, where we are putting out our patient information, the radiology, the pathology, timeline information of people who have finished their entire treatment and the events have occurred. and putting it out there for researchers to access. So this is through some DBT funded, biotechnology funded project. So the data would be available through DBT as well as through us, and that's a work in progress. It should be available in a couple of months or so.
Right. Doctor, I want to ask you about misuse of data. When we have so much of data in this country, and then you have, like we talked about the genes, like, there is no Indian gene. So the genetic pool is also vast. So this kind of data can fall in wrong hands too. So how do we keep to that privacy element? How do we make sure that data is protected in this country?
So a lot of this, the responsibility of this lies not just with the custodian of the data. So as hospitals, we are custodian of patient data. We don't own the data, we are custodians. The patient owns the data. The patient himself is responsible, the custodian is responsible, and the person using the data is also responsible for it. So as custodians, when we release any data to the public or for wider use, or even when we share as a part of a collaboration or etc., we take a lot of effort in ensuring that no identifiable information is shared along with this.
Okay. For example, let me just break it down. If you were to collaborate with, say, Johns Hopkins, then you would give my pathological data, but you will take out my name, and then you would give it. Is that what you're saying?
So names, identifiers is one thing, but we also at times anonymize in terms of time period. So for example, there are certain diseases which are very unique to certain populations. That even if you don't tell the patient name or etc., it is very easy to pinpoint on a very small group of people that this essentially happens only in this population. So we also anonymize in terms of time. So instead of putting actual dates, we put some days from, let's say, the date of birth as one of the. So instead of putting actual dates, we put that. There are other ways of anonymizing. A lot of these data is there, and how much anonymization enough depends on the technology. So, for example, if today there are some AI models which can look at X-rays and tell us whether the patient will die in the next 5 years. They at times, even on pathology slides, the model can at times identify male and female tissues, which the human eye cannot. So it all depends. How much anonymization is enough depends on what technology is reading it. So we don't know that. This thing will come to know.
And are you finding doctors more adapting to AI? And what about patients? Are they also accepting towards AI, or is there still this dependence or more faith in the human intervention in this?
As a general rule, there is a faith in the human intervention, but the human intervention is not going to disappear. The AI models are only be used as a medical device. So the decision, the responsibility, the legal, etc., everything going to rest with the person using the device.
So, in this list of, these jobs are going to go away because of AI coming, like, for example, proofreaders are gone, right? Even editing is gone. People who were checking the grammar in our profession, at least as journalists, in our profession, those who were checking the grammar, now you have apps, you put it in through the app and they check the grammar and gives it to you. In all that list, they're saying that doctors and paramedics, no, they're not going to get hit as far as jobs are concerned. You'll still need human beings to give that Medicare to patients. So they are not going to get hit. Their jobs are not going with AI coming in, because this is genuine fear in every profession now that will AI take my job away?
Correct. So every new technology displaces some older thing. Same thing will happen here as well. Certain skills will become redundant. So if you say that like robotic surgeries, the accuracy and the precision with which a robotic surgery can be done has helped patients dramatically. They even in fact negate the surgeon's tremors. If the surgeon has a tremors, the machine negates it, removes it from the picture. So the skill for a very high to have the hand entirely stable has gone away. Okay. Some skills will definitely be repurposed. You will need doctors. Doctors as an entity will not go away, but doctors who use the AI will replace doctors who don't use the AI. That is what I foresee. That my mind and time will be taken away from the repetitive task, and I will do some other task more than the same counting of cells or counting of tumor
Correct.
types or measuring
Yeah.
the tumor. Instead of doing that, I will do something else. So that is definitely happening.
Thank you so much, Doctor, for speaking to us and telling us and explaining to us and giving us hope that these frightening statistics that we have, AI will help us in reducing the number of cancer cases in this country and helping in not just diagnosis but even in curative processes too.
Definitely. Thanks a lot. It's a
Thank you.
pleasure to be here.
Thank you. Thank you for watching or listening to this edition of the ANR podcast with Smita Prakash. Do like or subscribe on whichever channel you have seen this or heard this. Namaste. Jai Hind. Click here to watch the previous episodes.